We will go ahead and get started today. Thank you so much for joining us today for our sixth HIV ECHO session. So we are the University of Nebraska Medical Center Specialty Care Center, and we very graciously welcome you all to our sixth HIV ECHO session today. And it is titled Trauma Informed Care. And we are super excited to have our special guest didactic presenter, Mahelet Kebede. And then today's case study will be presented by SCC's own Jen O'Neill. And then my name is Heather Sorella. I will be your HIV ECHO facilitator today. And then our sessions are held the first Thursday of every month, except for July 2025. And then just a little disclosure about our project, but our HIV ECHO project is made possible through grant funding from ViV Healthcare. And it is a sub-project of our larger I'm Capable research project. And this is just an agenda for today's session. So Mahelet will be presenting us with some more didactic information regarding Trauma-Informed Care 101, just to help us sort of improve our knowledge on all of those things. And then Jen O'Neill will be presenting a case study after Mahelet. And I just want to say that I think this case study is really important regarding the topic of trauma-informed care. And I think we'll all learn a little bit more about how to better work with patients and the public. And then I'll have some announcements to share at the end, and there will also be a feedback survey link. And then ECHO after hours, so as scheduling and time allows, some of our experts might be able to hang on for a couple minutes after sessions just to answer any lingering questions or anything. And so Mahelet and Jen will be able to hang on for a couple minutes if anyone has anything else they need or want to pick their brains at all. And here are just some housekeeping reminders for the session. So we love discussion. Feel free to throw any questions or comments in the chat. I'll keep eyes on that. Please stay muted unless you are speaking. One Devo, one mic. We do our best to stick to that rule. And then we love to see your face if you're comfortable having your camera on. No troubles if you're unable to today. And then sessions will be recorded. We don't record the case study portion just for confidentiality purposes. And then, as I said, there will be a survey link at the end. And now I will hand it on over to Mahelet.
Thank you so much, Heather, and good afternoon, everyone. My name is Mahelet. I use she and her pronouns, and I'm excited to be here with you all today to talk about a topic that I'm very passionate about and have been doing work on for about the last decade, and that is trauma-informed approaches. Specifically today, we'll be talking about care as an approach to being trauma-informed. Next slide, please. Can go ahead. Next slide, please. So what I am aiming to accomplish with you all today is to, number one, describe neuroscience, which is a bit of like the background, the scientific background that researchers are using to better understand trauma. We're going to walk through the 6 trauma-informed principles. These are principles that were developed by the Substance Abuse and Mental Health Services Administration and act as a sort of anchor to trauma-informed work, regardless of the sort of topic area or the field that you are covering it in. And then third is to talk about a couple of examples of what being trauma informed or the inverse, really, right? Potentially causing re-traumatization to the folks that you all work with can look like when we look at the continuum of care in HIV. Next slide, please. So just really quickly, I like to do a temperature check to get an understanding of where folks are at. If you want to just come off mute and kind of like shout it out or drop in the chat box, what do you think of when you hear the word trauma? So when you hear that term, what's the first thing that comes to mind for you? Scared, highly disruptive and scary event. Okay, so what caused the trauma? Unsafe, a bad accident, fear, harm, childhood. We'll be talking a little about that. Injury, hurt, pain. I go to physical trauma. Okay, so I'm hearing kind of a mix of what caused the trauma to happen. So, what was the traumatic event, as well as maybe the physiological or psychological impact of that trauma experience. Difficult to process, things that hurt us, long lasting, pain, discontinuity in normal progress. Yep, we'll be talking about that as well. Thank you all so much. I'm surprised, typically when I say this, and it's probably because I'm talking to providers today, a lot of folks say PTSD. So I'm surprised, pleasantly surprised to see that folks think about trauma more broadly. A lot of times folks think about our veterans, right? Military veterans, which is fair, absolutely, right? We know that those folks experience trauma, but trauma really can look um, so different than just an experience of living through or fighting through war. So I'm glad to hear that folks are already thinking more broadly. Next slide, please. I like to ground us when discussing trauma. I think that that word can mean and look different ways for different people. So I just want to ensure that when I say trauma today, we're all on the same page about the sort of trauma I'm describing, right? So I have two terms here that I want to ground us with. So one, the definition of trauma. We are defining trauma as broadly defined, as experiences that produce intense emotional pain, fear, or distress. And these experiences often result in long term physiological and psychological consequences. So, these experiences of trauma, especially in childhood, shout out to the person who mentioned that, can change a person's brain structure. I want to underscore that, can change a person's brain structure, contributing to long-term physical and behavioral health problems. A couple of things I want to point out here. One of them is that the experience of trauma can actually change a person's brain structure. That's really significant, right? A lot of times we assume people are behaving in a certain way just because they choose to behave in a certain way. If your brain is structured differently, there is likely reasons that you're going to behave in the ways that you do, number one. Number two, what I want to point out here is that me and I'm going to pick on you, Heather, because you're the first person I see on my screen. Me and Heather can experience the same thing, right? So, for example, we could have both lived through the COVID pandemic. However, I could have received it in a way that it really caused a lot of harm, right, psychologically for me because of maybe I experienced significant loss. It was a really rough time for me. However, maybe Heather did not experience significant loss. So this is important to delineate because oftentimes we think that trauma is the event, right? Traumatic event is how we describe the event. Trauma, right, is the consequence of experiencing that event if it actually causes psychological or physiological results, right? Or issues for an individual. So I hope that delineation makes sense. Now, being trauma informed, right? That's what I am inviting you all to consider doing through this session. It's an approach to administering the services and care that you're already doing, but in a way that's a little different, right? It acknowledges that traumas may be active, presently occurring in someone's life, or that they have occurred in the past and that experience of trauma is manifesting in them physically, mentally, and behaviorally, right? So we're going to operate a bit differently because we want to acknowledge and address the fact that those traumas are active or that they may experience the effect of them if they happened in the past. Can I get a thumbs up from 3 folks? Does that make sense? Okay, I'm seeing more. Okay, awesome. And if you have any questions about these terms, since this is the foundation for our conversation, please go ahead and drop it in the chat and I will respond as we're going along. Next slide, please. So, neuroscience. So, I love to start off a TIA or a TIC, Trauma Informed Care session, on neuroscience or with neuroscience. NEAR is a acronym for neurobiology, epigenetics, adverse childhood experiences, or ACEs, as some of you may know them, and then resiliency. Don't run around to write that down and freak out if you missed it. We're going to literally walk through every single letter in the acronym, I promise. And what it does is provide a holistic understanding of how trauma and resilience impact health outcomes. So we used to have a really narrow understanding or definition of trauma, right? This PTSD concept. And this is neuroscience is now what researchers are using to better understand it more comprehensively. So we're going to start off with the N, neurobiology. I am not a neuroscientist or an expert, so don't ask me too many hard questions for this part. You all probably as providers can answer more than what I could. But what we're going to do is focus on the three parts of the brain that are specifically relevant to trauma, and that is the prefrontal cortex, the hippocampus, and the amygdala. So first, the prefrontal cortex, if you were to touch your forehead, that's the part that's like almost immediately right behind your finger, within your skull. And the prefrontal cortex has the nickname of the thinking center. What the prefrontal cortex does when it's strong, right, is that it allows us to be able to think clearly and make good decisions. We're aware of ourselves and of others. However, after trauma, particularly trauma experienced during childhood, there is a loss of neuronal integrity, right? Which is just a fancy way of saying that because the part of that brain is compromised, it's not able to communicate with other parts of the brain, which is incredibly important because remember, this is the thinking center, it's the logic. So I want you all to keep that in mind. We're going to talk through an example at the end that ties these three in, and we see how they almost like conspire against folks that have experienced significant trauma. So prefrontal cortex, thinking center. We go a little bit deeper, right, through our forehead into our brain. We're going to hit the hippocampus, aka the emotion regulation center. When this region is strong, right, haven't experienced trauma, we can manage difficult thoughts and emotions, and we can recall and recognize memories. So individuals who have had traumatic experiences, they might experience vivid memories or persistent thoughts that are reminiscent of a trauma, right? And that's important because remember, the hippocampus is not able to communicate, remember, like we said a second ago, with the prefrontal cortex as well. So if I'm having a really vivid memory and I haven't experienced trauma, I'm able to remind myself, hey, that's not happening right now, right? We're not there in that moment. This is just a memory you're having. Now, we go a little deeper down towards the brainstem and we get to the amygdala. Our amygdala, has anyone here, just by a show of hands or emoji, has anyone ever heard of the fight, flight, or freeze response? Yeah. Okay. I'm seeing some nodding heads, some thumbs up. Awesome. Okay. I think a lot of us have heard of that before. It's pretty commonly referenced. Our amygdala is the part of the brain that is responsible for that response. So the amygdala is also known as the fear center, right? It responds to stress or anxiety that we're experiencing, and it coordinates the behavioral response to that feeling, right? The behavioral response can look like fight, flight, freeze, or fawn is a different response method that we're learning about in more recent years in research. So, in the traumatized brain, the amygdala is on high alert, right? So, whereas the other parts that we are discussing are like weaker, so to speak, the amygdala is opposite, like it is overcompensating. And so, this is what can lead to folks behaving in ways that we might deem as inappropriate or erratic, as defiant. I think that was a little, we saw some examples of folks mentioning that when we said, what do you think of when you hear the word trauma? And why that is happening is, so this is when we see the three parts conspiring. You are experiencing stress and anxiety, right? If you're, let's pretend you are a person who's experienced significant trauma, but your brain is not able to access that prefrontal cortex, which would then, send a signal to you of like, hey, let's apply logic to this situation. We're not actually in a stressful situation or anxiety inducing situation, right? And so, this is what I mean when I say it's like the parts of your brain conspire kind of against you. And so what happens for an outsider looking in is they're like, why is that person behaving in that way? That's such an overreaction. Meanwhile, for that person who's experiencing feeling triggered and reacting in a way, It is actually a perfectly logical response to the situation that they are perceiving. So I'm going to use a quick example here. Many of you work at health centers, um, you work at a hospital, these sorts of settings. So you've probably had or experienced a patient who's coming into your waiting area. They've been waiting a long time because it's just a really busy day in clinic. They are due to receive some test results, and they are already anxious because they're anticipating their test results. Maybe they're coming in to do their semi-annual right check on where are you at as far as viral suppression, and they hate this time of year because it's always just, I know I've been taking my meds, but I don't know. Am I going to be detectable again? I'm antsy. It's crowded. And they're becoming more and more aggravated. And now they're escalating in your waiting area, right? They're raising their voices or becoming really testy with your administrative staff, right? That's at the front desk. What you're likely seeing is some sort of amalgamation of a prefrontal cortex and a hippocampus not doing what they need to be doing, and the amygdala telling this person, like, you should be on high alert, fight. These people are dismissing you. They're not taking you seriously. They don't respect your time. Maybe they smell a scent that reminds them, right, of a vivid memory of the past. And so now they're not totally with you in your clinic. They're snapping back to a memory of that scent and something that they experienced when they were smelling that scent. And the logic, it's not coming through because their prefrontal cortex is not, at its optimal level and able to apply logic to the situation. Does that make sense? Just want to do another temperature check. Some thumbs up. Okay. All right. Again, please drop questions in the chat. We're going to go ahead and move on to the next letter in our acronym here. And I believe I skipped the E and I hopped down to the A. So if we could go to the next slide, that's going to be adverse childhood experiences, or ACEs, as some of you might know them as. So ACEs are kind of grouped into three categories: abuse, neglect, and household dysfunction. Don't go into a lot of detail about each of them. There's a whole ACEs survey that you can find online because the questions themselves can be triggering for folks. But essentially, the original ACEs study, it started off as a study, was conducted by the CDC and Kaiser out in California. They surveyed over 10,000 adults that were receiving care at Kaiser, and they asked them a series of questions. Again, you can see those questions online about experiences of childhood trauma that these individuals had. And what they noticed is that there was a relationship between the amount of experiences of childhood trauma or adverse childhood experiences these individuals had, along with a risk for poor or negative health outcomes. And I'm going to talk about some of those health outcomes in just a moment here. But essentially, it's right, it's a dose response, a dose exposure response. So the more ACEs you have, the more likely you are to experience a multitude of those risk factors. The less you have, the less likely you will experience those negative health outcomes. One thing that I always like to share with folks that they took away, right, a key takeaway from this study is that most adults actually have had at least one traumatic experience. However, the percentage, right, then significantly reduces when we're talking about four or more ACEs, which is what we then consider significant experience of childhood trauma. Next slide, please. So, what are some of those negative health outcomes we're talking about here? They look like chronic disease. They look like risky behaviors. I don't love that terminology. And they also look like an impact on opportunities for higher education, right? Steady income, steady career or occupation. And the one that I think is most relevant to us, I'm trying to circle around it. I'm realizing I'm not sharing slides, is infectious disease, right? Is the risk of acquiring HIV or acquiring sexually transmitted infections. Next slide, please. We're going to now go backwards, and the reason I do so will make sense in just a moment here. But we're moving from the ACEs, right, childhood trauma experiences, back to our E in neuroscience, and E stands for epigenetics. So epigenetics is the study of how our behaviors and environment can cause changes that affect the way your genes work. So there is not a genetic mutation or anything that's happening here when people experience trauma. However, there is a potential. Epigenetics is still a relatively new field of study, so we're taking it with a grain of salt. But there is a lot of promising research that shows in the way our DNA is read and coded, that part can change, right? So your DNA is not necessarily changing when you have offspring if you have experienced significant trauma. But this video explains what that does actually look like. So let's go ahead and play that, please, Heather.
It's okay.
Protect your family's dreams under our roof. American Family Insurance.
Wix, one platform. Any website. Unlimited creation.
The sweet smell of fruit doesn't normally send rats running. But when researchers paired the orange, cherry, almondy scent of the chemical acetophenone with a painful electric shock, lab rats quickly learned to fear it. Along the way, extra neurons sprouted in their noses and in the smell processing center of their brains, making them super sensitive to the scent. This result isn't shocking. What is surprising is that the rats' pups and their pups' pups were also startled by the smell of acetophenone and had the same extra neurons as their fathers, despite never having been introduced to either their dads or the fruity scent before. But how could the pups have inherited something that their fathers learned? Basic genetics tells us that only DNA gets passed along to offspring. Characteristics like memories, scars, or giant muscles can't get passed on since acquiring them doesn't alter the genetic code. But it turns out that instilling fear in the rats did trigger genetic changes, not in the DNA sequence itself, but instead in how that code was read and used in the rats' bodies. In every cell, biological machinery constantly translates DNA into the proteins needed to carry out vital processes. Chemical switches attached to the DNA turn genes on or off or up and down, telling the machinery which proteins to produce and in what quantities. These switches, called epigenetic tags, are why a kidney cell looks and acts differently than a skin or nerve cell, even though all three cells have identical DNA. But the switches in any one cell aren't set in stone. Teaching those rats to fear the fruity smell switched one of their smell-sensing genes into overdrive. Researchers don't know all the places in the rats' bodies where this switch got flipped, but they know it happened in one key set of cells, the rats' sperm cells, which would one day pass along the tweaked genetic material, making the next generation of rats super sensitive to acetophenone. Rodents aren't the only creatures demonstrating this weird type of inheritance. In Ivakalik, Sweden, boys who suffered through tough winter famines went on to have super healthy sons, with extremely low rates of heart disease and diabetes. And their sons had the same excellent health, living an unbelievable 32 years longer on average than the grandsons of boys who hadn't gone hungry. To be clear, this does not mean that we should start starving our kids for the benefit of future generations. Scientists don't even know yet exactly which switches the Swedish famines flipped. While we have been able to connect specific epigenetic changes to health effects in mice, we're a long way off from being able to make those connections in humans. That may sound like a bummer, but it's mostly because we humans don't live in the well-controlled environment of a laboratory. And for that, we should be grateful.
Thanks, Heather. So I think it's important to understand kind of how these concepts layer one on top of another. So there is a conceptual framework that was created for ACEs or for childhood trauma. And if you look at where I have that red line going across and above, the conceptual framework that was created was a pyramid. And so it starts off with someone experiencing, right, adverse childhood experiences or childhood trauma, right? And what our research, or not ours, excuse me, but what their research showed was that that could potentially lead to disrupted neurodevelopment, right? We were talking about neurobiology and the parts of the brains that can be impacted or are impacted by trauma. That eventually leading to social, emotional, and cognitive impairment. which then potentially leads to risk behaviors, right? Um, we talked about how some of those risk behaviors can lead to infectious disease, chronic disease, other social problems, and then ultimately leading to early death or compromised quality of life. And so this was the conceptual framework and how researchers had understood adverse childhood experiences up until this layer of epigenetics was added to the picture. And so what you see under that red line are the two new sort of levels that were added in to researchers' understanding. And this diagram is from the CDC, unfortunately not available on their website anymore, but we will be sharing these slides and follow up. So feel free to borrow shamelessly. But it's those two layers we talked about, right, with epigenetics. So generational embodiment or historical trauma that is experienced by the ancestors of this individual, right, who might have had an adverse childhood experience. And then also there's our social conditions, right? We're not going to get into that much today, but I'm sure you all have discussed in other sessions of the ECHO things like the social determinants of health, right? Where you live, learn, work, play, and pray, and how that can impact your health outcomes or your trajectory, really. So let's go to the next slide, please. And I think we're rounding ourselves out with our R, resilience. So things feel a little grim once you've gone through the N, E, and A of neuroscience. And so I like to say that I think resilience is kind of like that light at the end of the tunnel, if you will. Not everything is grim with trauma. It's really important that we don't pathologize trauma. You can heal from trauma. You can learn to cope from trauma. And so resilience is what, again, researchers are coming to understand as what can mitigate that trauma. And so resilience is a little bit of a tricky thing to define. It's still pretty early on in the years, again, relatively speaking, of research that's been conducted on it, scientific research, I should specify. So there's not a single accepted set of components of what makes up resilience. What I have here is a list of what is seeming most promising from some of the preliminary research that's been done, right? And I put an asterisk next to social supports because that has come through as probably the strongest component of resilience. So a person having social supports, right, a support system, having some sort of moral compass. I'm just kind of popcorning around here. Having a sense of purpose in their life, right? So all of these things, if the person possesses these characteristics or has them in their life, they're more likely able to cope with those traumatic experiences they've had, which then would seemingly lead to a reduction, right, in the sort of manifestation of physiological, right, psychological consequences of trauma. So this kind of rounds out our background in understanding of neuroscience. So as I transition to the next slide here, because we're kind of leaving this concept, I want to just pause and see if there's anything I can clarify about neuroscience. I'm not seeing anything in the chat. Okay, I'm getting a thumbs up. Awesome. All right. So I will move on to our next topic here. And really, we wanted to kind of give an honorable mention to intersectionality because you are going to see this come up in our case. So intersectionality is a term that was coined by Kimberly Crenshaw, who is a research scholar and an attorney, kind of by training and formerly by practice. And so when she was doing some work in the 90s, she noticed in a case that she was doing, it was actually against Ford Motors, the car company, that there was an impact that she was sort of witnessing or seeing in her representation of employees of Ford Motors that were both Black and women. So at that point in time, we have these protected classes when it comes to labor relations and labor or employment law. And race is one of them. Gender also, right, is a separate one. And so what she had deduced from working on this case was that if you possess more than one marginalized identity, right, and the graphic you're seeing here is just a couple that I think are most relevant to our work in HIV. But let's say that person is in a marginalized class, like they're lower socioeconomic status or working class, and they're also a woman. The compounding effect of those intersecting marginal identities is more significant than if we were to just look at someone who is a woman, or if we were to just look at someone who is working class, right? And so she coined the term intersectionality as this sort of theory that this overlap of social identities, in particular those that are marginalized, right? They can compound and contribute to systemic oppression and discrimination experienced by an individual. So essentially, what she's saying is you can't look at race plus class, right? You have to look at it as the combined a social identity to fully understand what the impact is for those individuals. And one of the resources I'm going to reference for you all, or we're going to reference for you all in follow-up, goes into a little bit more detail about intersectionality, but I'm just going to pause there for time's sake. And I want to tee this up. Again, keep the concept of intersectionality in mind as we go into the case study. So, what I think is important for you all to take away, and I'm going to have to abbreviate. I had an ambitious slide deck for you all. I'm going to have to abbreviate what I go through. But I think one of the main takeaways I want you all to have from this first part is when we're thinking about trauma and people who have experienced trauma, is to shift the question that you kind of reflect on and ask yourself. Maybe you don't say out loud what's wrong with you when that person is in your waiting area and they're raising their voice and they're behaving, erratically. But to shift the question you might be asking yourself in your mind, right? What's wrong with this person, to what happened to you, right? To really grounding ourselves in empathy, understanding what could this person have experienced that might explain why they're behaving in the ways that they are, right? And people don't just typically, at least, just behave in a way for the sake of behaving in a way, right? Typically, people do things for a reason. They might not be able to articulate that reason to you at that moment. They might not even know why they're behaving in that way, right? But it's really to center this kind of empathetic questioning or understanding, interrogation, if you will, of the situation that you might be witnessing. Next slide, please. So I'm really quickly just going to do a shout out of two things because I'm out of time here. So the principles we talked about earlier, really briefly, I had mentioned in our objectives that there are these guiding principles that were developed by the Substance Abuse and Mental Health Services Administration, or SAMHSA. And then I'm going to talk really briefly about the HIV care continuum. So the 6 principles are safety. When we say safety, we mean emotional and physical. It's trustworthiness and transparency, right? You can't have one without the other. We know that more transparency yields to trustworthiness between providers and patients, between staff and other staff, right? Peer support. Peer support can look in 2 ways. Your patients or your clients, right? Having peer support with or from one another. And same thing for staff. Staff having peer support, again, from one another. 4 is collaboration and mutuality, right? So if there's a sense of collaboration across power dynamics, right? So I, as a provider, seemingly hold the power when we're in the exam room, right? And we're kind of going through a patient's visit. What can I do to make that patient's experience more mutual? So I might have an idea for what this person's treatment plan looks like. Maybe it's a conversation, more of a prescription of like, here's what we're going to do for your treatment, right? Really thinking through what's the flexibilities that I might be able to build in that allow this to be a mutual or a more collaborative experience, so that the power that has often been taken away from folks who have experienced significant trauma, that power shift goes a little closer towards, right? That pendulum swings a little closer towards our patients. 5, empowerment, voice, and choice. This kind of goes hand in hand with 4, right? What are we doing to create spaces where folks have choices in their care? Are we allowing space for their voices to be heard, right? And that in and of itself, right? That voice and choice yields folks feeling empowered. Finally, is cultural, historical, and gender issues. So we talked a little bit about epigenetics. What I didn't mention, some of the initial studies on epigenetics were actually on the descendants of Holocaust survivors. There has been research that has happened since then around the descendants of folks that were a part of the transatlantic slave trade, indigenous communities who have been displaced and torn apart due to colonization and other historical experiences. We can also talk about on the gender side, right? Gender identity, which is really big, and sexual orientation in the communities that we work with. So really just having an eye towards what are the experiences of this individual that I'm working with, considering all of the social identities that they hold: race, class, gender identity, sexual orientation, etc. So just some guiding principles to keep in mind. And the last thing I'll mention in the continuum, I think that's the next slide here, Heather. Oh no, I went through all 6 of these. You can just hop through. You all will have this to reference. I was going to try to go through each of the principles in more detail. Again, very ambitious. But I'll just speak to it as you fast forward us through, is the HIV care continuum. You all know it. I know it. We're all familiar with it. I don't know how much we love it. I was going to say we all love it too, but that's probably, I'm sure everyone's so tired of looking at continuums. Something I just want you all to keep in mind. There are opportunities for us to re-traumatize our patients as they are sort of graduating through, which I hope they never do. I hope they always stay in pre-diagnosis, but the reality of the world is that some folks will advance through this continuum. There are opportunities for us to re-trauma. How are we delivering the diagnoses, right? What are we doing to retain folks in care? Are we offering them choices, etc.? There are also opportunities for us to engage with folks in ways that are healing, right? How are we offering wraparound services? Are we coming from a space and a voice of radical empathy for our patients? Are we offering peer support spaces where they can connect with one another, commiserate in like pill fatigue, or if I've got to do another injection one more time, I'm so over it. They can talk about how they've reframed HIV. I know one person I work with actually on a focus group when we were creating these tools said that I consider HIV my superpower because before my diagnosis, I couldn't get dental care, I couldn't get medical care, I couldn't get all of these things. And I have reframed it to think of it as a superpower of mine, right? That's like so amazing that this person had the support system and the vision, right, to reframe in that way. That's an opportunity for healing that was created for that person. So I just want to invite you all. And again, Jen will walk us through a case study. I think that will really illustrate the opportunities for healing and also for re-traumatization. That's important for us to keep in mind.